So thank you very much for the kind invitation. Yeah, I will discuss a little bit on the role of the vaccine stabilizer, having a focus on PEGs and polysorbat, and what we have learned here from and during the pandemic with anaphylaxis to the vaccines. So I think all allergists has some memories of that date, a date where all media pumps out with the risk of allergic reaction when we started to get the first mass vaccination in the UK. And I guess all of us thought somehow that we're gonna be involved in some more consultation than usual. And indeed, if you look a little bit also of how the different learned society reacted, you can see that basically it was pretty heterogeneous in the guidelines that were asked. And what we can say is that very quickly we had the belief that there is a link with the excipients in this kind of allergies. But anyway, if you look among the learner societies, everyone has slightly different guidelines, except for one that was to recommend an allergy consultation. And so maybe to try to understand the role of the excipients in this kind of allergic reaction, the first thing we have to do is to understand how these vaccines were made. And basically, mRNA vaccines are nanoparticles that are made from RNA that is mixed with lipids, and these lipids are also containing the PEG. And so why do we need to have the PEGs? Basically, when you increase the pH here in this solution, you will promote the production of micelles, and these micelles gonna fuse each together until they reach a stabilized form. And to have a stabilized nanoparticle, you basically need these PEGs molecules. So your nanoparticle of vaccines are basically surrounded from PEG or polyethylene glycol molecules. So what is polyethylene glycol? So first of all, it's not propylene glycol. It's always often confused. Has different names, macrogol. They are linear polymers that consist of a repeating unit of ethylene oxide. They have different size. The lower size are rather liquid, and the higher size among 3000 are rather solid. They have been used, as I just mentioned, in the mRNA vaccines as a PEG 2000. And PEGs basically are found everywhere. You find that in cosmetics, you find that in hydrolytic gels, in food. You have that also in many drugs, namely also in laxatives. And this is why probably we are very often exposed to that kind of molecules. And we can imagine that we can have some covalently bound molecules, and we can start to make IgG as it was suggested just with the previous talk. And indeed, you have some papers who have demonstrated, or at least suggested, let's say like that, that anti-PEG IgE exists, and they have tried to set up an assay where they could measure the level of anti-PEG IgE, and this could correlate it if you compare the cases of anaphylaxis and the control ones, where in the controls you have no IgE or low level of IgE as compared to the case of anaphylaxis, where you find a higher level of anti-PEG IgE. And very interestingly, also in many people, you can find some anti-PEG IgG. Okay, what you have also to know about PEGs or polyethylene glycol is that they can be found, this structure, in the polysorbat. So this is why we have some cross-reactivity with polysorbat. And basically, polysorbat is a hydrophilic ethyloxide sorbitan that is constituted with these ethylene glycol molecules, and that has also an hydrophobic carboxylic acid. I'm talking of polysorbat because it's also used in many drugs to stabilize the drugs. And so if you think of a protein, many of these proteins are actually amphiphilic, and that means that they can aggregate together. And so we have to be careful if we want to maintain their stability and their function to add what we call this kind of surfactant that are polysorbat. And by adding more and more polysorbat, so depending on the amphiphilic activity of the protein, you will be able to generate some kind of micelles and stabilize your protein. And this is why you have different amount of polysorbat in different drugs. I'm just showing here a list like in the Johnson that use polysorbat to stabilize his viral particles, or in other vaccines. In infliximabs, in the context of antibodies, we're also often using polysorbats. Okay, so that being said, that's why I talked about CARPA, because a lot of people still think that PEGs or polysorbat can be involved in CARPA reactions. And how does it really work? And the idea here is that you have indeed some anti-PEG IgM that can bind directly to these PEG molecules, and that can trigger the activation of the complement. And once you have the activation of the complement, that will secondly activate your mastocyte and basophil, and you can have what we call this pseudo-allergic reaction. So what evidence do we have to say that CARPA could exist in the context of polysorbat reaction? And this is, I think, one of the nice study, although we don't have much repeats of it, who could show in vitro that if you take a drug that contain polysorbat, basically you can provoke an activation of your complement. And this is measured by the soluble complex attack, the 5B9 complex attack of the complement. And this was really specific to the drugs that has some polysorbat or cremophore. It's also a molecule that is very linked to the polysorbat or PEGs. Okay. So, indeed, we had some allergic reaction. So the number of allergic reaction was always a matter of debate. So exactly how many. This is a nice review that looked at every papers that has reported some allergic reaction. And what I want to emphasize here is to say that it was really heterogeneous. So the only thing I really don't like is the scale, because you see the scale between 0 and 100 is so close together that you have the impression that the number of anaphylaxis was always similar. In fact, it was very heterogeneous among centers. And so you have some anaphylactic reaction that can go from 100 patients per 1,000,000 dose to only 1. And so this was always a matter of debate. And the question was, how do we should manage these people with anaphylactic reaction? And the first thing people tried to do is to do a skin test for PEG or polysorbat. And from that paper, they concluded that skin testing for polysorbat or PEGs was only, unfortunately, very limited. Because if you now provoke or try to provoke people who had positive skin tests for PEG, you had some people who could tolerate the dose, while you have people with a negative skin test who could indeed have a reaction. So the conclusion of this paper is that testing directly with PEGs or doing skin tests with PEGs is actually pretty limited. And the question, obviously, that we had is why should we not use directly the vaccine to try to assess the allergic reaction? And I'm just showing you here the AACI position paper on that topic, and they recommended basically only to do prick-to-prick test with the vaccine and try to save as much as possible the mRNA vaccines to avoid any waste. And therefore, they were not good recommendation to try to do such a skin test. What I can say is that in our experience, skin test, and in particular intradermal reaction, works very nicely. So we can find a very nice positive EDR, and you see for the Moderna vaccine as well as for the Pfizer vaccine. And not very surprisingly, you have this nice also correlation with the polysorbat who can show reactivity. So this is the case of a patient that had an anaphylaxis after taking some laxatives. Should we do a prick-to-prick skin prick test or intradermal reaction? Our opinion is that rather not, because if you look on all the patients we have tested in our clinic, more than now 134. We found we found 30 patients that had both IDR positive reaction for the Moderna vaccine and for the Pfizer. But you can see only one of these patients had a prick test that was positive. So I think our data really suggests that if you want to look for a sensitization to the vaccine, you should go for intradermal reaction. This is also confirmed with basophil activation test, and if you try now to test both vaccines with these patients that are sensitized or have positive skin tests for the mRNA vaccines, you really nicely show that the ones who have a positive skin test have a positive BATs when you look at CD63 upregulation. And the polysorbat was a little bit less clear, but again, the significance is really with both mRNA vaccines. And there's a very nice correlation with the skin test. So if you have a negative skin test, you are very likely to have a negative BAT. But if you have a positive skin test, then you are very likely to have a positive BAT. So what is the mechanism of this activation? One is to ask the question whether IgE are involved in that, and the experiment we did basically was to use ibrutinib, and the idea of ibrutinib is that you can selectively inhibit the activation of the basal field that is mediated through the IgE pathway. And in this context, you see if you use anti-IgE, you have a nice upregulation of CD63 expression. And if you use ibrutinib, now you have a significant downregulation. And this is not true if you use a bacterium-derived peptide, the FMLP. And here, with the FMLP, you have absolutely no difference in the level of CD63 expression. So really suggesting that the ibrutinib selectively inhibit the IgE pathway. And if you apply ibrutinib on the bat with the vaccines, you see that you have a significant downregulation that was even more obvious for the Moderna vaccine. So that really suggests that indeed we make IgE against the vaccine. So I'm coming back to this notion because a lot of people think that CARPA, and I will explain you a little bit later, are still involved in the mechanism of allergic reaction in these patients. A simple experiment, we try to see whether the complement may have a role in the activation of the basophil, was simply to take the blood of someone that are vaccine sensitized, to take out the serum, either inactivate the serum by putting it at 30 minutes at 65 degrees or putting it on ice. And then we replace the serum in the bat of another tubes, and we try to do our bat assay. And what we observe is that, so it's only one cases, but the level of activation in between all conditions was exactly the same. So this, to our opinion, suggests that in this case, the complement is at least not involved in the activation of our basophils. Another things we have also tried to test it in the lab is to see whether we can use fresh or cryopreserved vaccines. And you know, we have this limitation of accessibility to the vaccine, and the question is now, what can we use, and how can we get this vaccine? Because now we have less and less vaccination, for instance, and so we have tried to look at correlation between freshly harvested vaccine and frozen ones, and you can see here, this is true for the Moderna as well for the Pfizer. You have a very nice correlation between the Moderna and the Pfizer and the fresh and cryopreserved vaccine. So it suggests that what we can do is basically cryopreserve our stock of vaccine and use that for our bat assay. We even tried, you know, to cryopreserve that different days after we got it. We waited until 16 days, and you see that even if you get the vaccine very late and you froze it 2 weeks later, it's still efficient, and you have exactly the same level of CD63 expression that is induced. Okay, so why people are not convinced about IgE-mediated anaphylaxis in the context of the vaccination? And the main reason is that when you re-challenge them, and that's this meta-analysis would have looked at all the studies who have tried to do that. Basically, upon re-challenge, you have very little severe reaction. And the idea is that if you would have an IgE-mediated reaction, it could be that you should have a very severe reaction that could be promoted. And actually, it's true that most of the patients that we re-challenge with the vaccine can tolerate it. You have to be careful. It does not favor severe reaction, but people actually react. So they have some small reaction, but they don't have a major severe reaction. So what we have done in the CHUV with patients who had an anaphylaxis and we found the sensitization, we started to do this 5-step induction protocol. And here the idea is to split the dose into 5 smaller doses. And we have compared a different group of patients. One are the ones who had an anaphylaxis to a component that contained the similar excipient than the vaccine, so PEG or polysorbat. We have tried to do this also with patients that are sensitized to the mRNA vaccine and who had only an allergic reaction but without criteria for anaphylaxis. We did the same for some of people who had an anaphylaxis. And we also tried this protocol in patients who had a hypersensitivity reaction that were not tolerated upon re-challenge, despite the fact that they had a negative skin test. And what you can observe is that people that has this prior anaphylaxis component to the component of the mRNA vaccine tolerated very well without any issues. That is also true in the context of patients with allergic reaction without argument for an anaphylaxis. Now, when the reaction was more severe, what you can observe is that in one case we had to stop the vaccination process, and in 2 we could finish it, but they still had some symptoms. And the more striking ones is the ones who had negative skin test, who still didn't tolerate a 10% re-challenge. When we tried this 5-step protocol, it didn't really help because one of the 2 patients we could not finish the vaccination. The other we could finish it, but still had some also reaction to it. Is it safe for just as an immunization point of view to vaccinate people with a fraction dose? And we measure the serology of these people who get either a 10% fractional dose, a 2-step dose, 10-90%, or this 5-step induction protocol. And what we can observe is that with the booster response, you have similar level of upregulation of your antibodies for the SARS-CoV-2, independently of the way you get your vaccine. If it's 100%, if it's a 2-step, or it's a 5-step vaccination protocol. So I think these are also really reassuring data that we can split the dose to vaccinate people who may have had some allergic reaction. Okay, I will end here, and I will have to thank a lot of people in the CHUV, but also in our diagnostic tools. Also Daniel Yerli here, we could work a lot with him very successfully. We had also the help of many allergists in the canton. We provided also some of the patient, and also we had these massive mass centers, vaccination centers, where many people were also involved in identifying patient with allergic reaction. And I thank you for your attention. I'm happy to take some questions.
So, question from the audience? So I have one. So we could see in the bat that actually the linear PEG were never positive, but actually that the polysorbat-80 was a little bit more cross-reactive with the compounds. Do you think that the 3D is something important, or if could be another factor?
So I indeed think that the three-dimensional construction is really important, and this is explaining why not everyone who has anti-PEG antibodies has anti-polysorbat antibodies. So the cross-reactivity probably between these two drugs is only between 30–40%. It's not 100%. So that really suggests that the tridimensional structure of the polysorbat may play a role. I know also that for the PEG bat test, so the PEG for intradermal reaction is really bad. So we had zero reactivity, almost zero. So we don't recommend to do it. And indeed, also with the bat, the PEG was not very useful to identify sensitized patients.
Yes.
Since here there are a lot of clinicians that have a long experience, have you never experienced the very same kind of anaphylaxis in several other drugs that have the similar pegylated structure, like the doxil, that is the epegylated doxorubicin, that is exactly similar to this vaccine, or there is the carboxypeptidase, that is again a molecule with a very similar folding. Is this something already discussed at clinical level?
I think it's still a very new topic, to be honest. And I mean, all the papers are less than 10 years old. And I think we still have much to learn on the exact mechanism and on the cross-reactivity that we can find in between drugs and the reason why we find it, and sometimes yes, sometimes no. But obviously, it's something we have to consider when we have someone that is vaccine sensitized, and then we recommend to the patient to stop all drugs that has a component that may contain excipients that could cross-react with the PEG of the mRNA vaccine.
Yeah. And I remember also one of the first patients who sent us for developing this bat had also cross-reactivity with Taxol that used a chemophore that is very similar. Then it was really cross-reactivity or something else we didn't dig.
But it's true that we have some patients that are vaccine sensitized without argument for and quite a lot for polysorbat vaccination, so polysorbat hypersensitivity. So it could be that there is also specific antibodies that are just recognized in the context of the mRNA vaccines and not for other drugs.
Yes.
Thank you for your talk. I have a very practical question. So if you have a patient who show a positive skin test to one of the vaccines after having an anaphylactic reaction, you could desensitize the patient or to give him the vaccine with your desensitization protocol. How do you counsel this patient what do you recommend the patient to? Can they receive drugs that contains polyethylene glycol in future, or do you provoke with?
Yeah, but it's a very good question. But we recommend, at least, we have no restriction for oral drugs because here the rationale to have a really high risk of anaphylaxis to oral drug that may contain some PEGs has never really been demonstrated. So, but now in the context of intravenous drug that could contain or contain some polysorbat PEGs molecules, then we advise not to do that and ask us for advice. Yeah. Oral medication. There's, in my knowledge, or the best of my knowledge, there's no strong argument to say that we should now start to restrict people to get, because the amount of PEG that we get through these oral pills is so low. Then we have the stomachs where, with the acidic pH and may also denature the PEGs. And indeed, it's only in the context of a huge amount of laxative, so. That's maybe the only drug. The only drug we make an exception is the laxative. Yeah, exactly. So except when you take a lot of PEGs. Yeah.